This clinical presentation has been completed on a medical case. This particular case interested me not by the findings or the presenting situation, but by the potential emergency it could have developed into. The dispatch case history. The case was given as a hemorrhage, or an LACS, a hemorrhage through tubes. It was a code 1B with code 1 ICP backup. It was a 14-year-old male patient with hemorrhaging through tubes, and this was all the information that we were given. On arrival, we discovered a 14-year-old male with a history of severe idiopathic pulmonary hypertension, secondary to an underdeveloped left ventricle and decreased ventricular output. The patient had a permanent prostacyclin infusion through a central line in his chest. The central line was damaged and causing a leak of the drug. Patient findings. The patient was asymptomatic on arrival. He had allergies to adhesive tape, and the medications he was on included prostacyclin, a vasodilator, bosentan and sildenafil to treat the pulmonary hypertension. His past medical history included pulmonary hypertension, an underdeveloped left ventricle and asthma. He last ate at lunch, and the patient was sitting on the couch when he felt the leak occur. Patient management. On arrival, the patient and family were reassured as the QAS followed the predetermined ambulance management plan that was already in place. On examination, the patient's vitals were all within normal limits, and the patient stated that he becomes lightheaded and breathless when there's a problem with the infusion, and also stated that he wasn't sure how long symptoms would take to present after the loss of flow. The patient remained asymptomatic in the presence of QAS. Following the ambulance management plan, IV access was successfully obtained with a 20 gauge on the right antecubital fossa, and the infusion line was then reconnected to the site. The medication was recommenced at the prescribed rate of 4 millilitres per hour. As the patient had allergies to adhesive tape, the site was then secured with a bandage and splint as a security measure to ensure that the line was not dislodged or bumped en route to hospital. The mandatory ICP backup arrived and was satisfied with the treatment that was given. The patient was then loaded into the ambulance, where a 12-lead ECG was completed, and although it showed signs of right axis deviation and right ventricular hypertrophy, which can be seen here, this was considered normal for the patient's condition. Then, following the management plan, the patient was then transported to the Mater Children's Hospital. The provisional diagnosis was an infusion equipment failure, and the patient outcomes. The patient remained stable due to the successful reconnection of the infusion line. He did not exhibit any of the symptoms that would be expected should the line fail in QAS presence. The patient and family remained calm and in good spirits on arrival to hospital. Clinical reflections. This job got my attention due to the age of the patient, the potential seriousness of his condition, and the fact that there was already an ambulance plan in place. What also got my attention was the urgency of the QAS in reaction to what appeared to be a relatively stable patient, and by the arrival of 3 ICPs. After further discussions with my mentor, I was made well aware of the potential seriousness of the patient's condition, and I now understand their reasons for their actions. After being patient care in the back of the ambulance, the patient informed me of the serious restrictions he has on everyday life. He told me of his inability to play sports like the other 14-year-old boys, and of the constant trips and checkups he has to undertake in hospital. He was aware of the fact that he'll be on medication for the rest of his life, but his greatest concern was the worry he caused his mother and sister. He told me he was embarrassed as he could not comprehend why there were 6 paramedics attending to him today, and he felt fine. Although he was aware of his restrictions, the innocence of this young patient hit me as he was experiencing such a serious condition at such a young age. From what I learnt from this case is that idiopathic hypertension, pulmonary hypertension, can occur from infancy into adulthood like it did for this young patient. That, combined with an underdeveloped left ventricle and decreased ventricular output, results in a serious prognosis with a shortened life expectancy. The infusion line was inserted into the patient's chest, directly administering prostacyclin into his heart. This potent vasodilator assists the heart to pump blood to the lungs and the rest of the body. I understand now the seriousness of a leaking infusion line, and I am now able to reflect on the possible outcomes that the patient could have faced should he not receive the drug immediately. I chose this case for my reflection due to the patient's rare and serious condition.